think this is live now, so we'll go ahead and get started. It's about 9 a.m. Central Standard Time, so time is of the essence. Hello, and I hope that you are having a lovely day. My name is Dr. Jonathan Kenigson, and today I'll be sharing with this international medical audience some of the research that I've had the good fortune of being able to create as a statistician, not as a physician, and it is my sincere hope that those among you who are physicians will find it both profitable and edifying to attend this lecture. The title of my lecture, very unsightly and unseemly, I know, but rather precise, has to do with the dosimetric properties of beta blockers in Asian patients who are already dealing with heart failure. Obviously, beta blockers have been a mainstay of treatment for a great deal of time 50, 60 years now. They've been in wide use and of various levels of selectivity and effectiveness. And the goal of my research for those here is to be able to ascertain the differences in prescriptive power in the quantity prescribed per day of medications in Asian countries as a function of their gross domestic product, median income, etc., and also to evaluate the effectiveness of the medications as they're prescribed because the doses differ quite a bit from country to country. So, with that said, let us get started. Here's the background. We have a rising prevalence of diagnosed and likely more undiagnosed heart failure. That is a global problem, is one of the top five strains on almost all health systems in the world today, whether they're national or private sector systems, whatever the disease prevalence and burden is quite high, and beta blockers remain a cornerstone of the therapy for heart failure, despite the advent of ACE inhibitors and sort of more advanced antiarrhythmics. These beta blockers are inexpensive. Their effects are fairly well understood at this point, and they've proven themselves time and again as helpful adjuncts to lifestyle changes in managing the burden of heart failure. However, for the purpose of our discussion, I'm not giving a discussion here on the physiology of beta blockers. Those work by inhibiting adrenaline at receptor sites in the heart and other places, as you know well. I'm principally interested in the regional prescriptive patterns that one sees in these sorts of medications in Asia and whether the doses they've used in the cohort studies that exist across Asia, that these are showing the same level of effectiveness as they have in the Western world. So more formally, let's go ahead and go to the statement of the problem for the sake of this discussion. Um, I'm arguing in this lecture that Western dosing has too high of doses for many Asian heart failure patients. And the reasons for these may be genetic. The reasons for these might be difference in polymorphism of the genes that are involved in the metabolism of the medicine. Another intriguing and interesting avenue of future research is to see if weight has a key role, average and standard deviation of weight from population to population. I was not able to do this in the current small study due to constraints of funding and data. So, what happens to affect the prescription of beta blockers in different doses across Asia? That's something that we'll see here presently. The purpose of the study is ultimately, pardon me, to explore the possible synergies with the sodium glucose cotransporter inhibitors, the ones that are now finding sort of their heyday in the commercials here in the Western world, recover your life with Farxiga, whatever. So these sorts of things we're looking to see whether the synergies here actually explore greater prescription in Asian countries or whether beta blockers alone are sufficient. As I'm going to show you, um, these inhibitors, SGLT2, are actually quite effective and well tolerated adjuncts to beta blocker therapy from a statistical perspective. So, presently, let's explore the methodology of our study in order to ascertain the dosing and safety outcomes for beta blockers and associated therapies. I did a narrative and technology aided review of the published data in the Asian HF Deliver DAPA HF trials. These are very, very large data sets, extremely large data sets that require sophisticated technology to query adequately and to obtain sample sizes. As a mathematician, I found this the most difficult aspect of the assignment that I had here because a lot of this data is fuzzy, a lot of it isn't in naive database form, and so one has to query the data very carefully and come up with responsible statistical extrapolations that do justice to the original data, okay, without introducing biases into the research. So here, um, the principal source of my work was the Asian HF registry. There was the Deliver trial, as we've said, there's data. There have been a number of smaller cohort studies associated with beta blocker use in Asian heart failure patients. And for those, I use standard meta-analytic techniques, method of moments techniques that proved to be relatively useful despite the complexity of the data, even though we have a linear proliferation of these studies that are small, pooling the studies and computing pooled variances and standard deviations and data review of that for method of moments is relatively straightforward to those in the know. However, it is computationally tedious, which is why probably no one has done it before. I was the only one probably who had the chutzpah to come in and use regular query tools to attack these data sets and look for the properties I wanted. So these are the data sources. And we had to clean the data a little bit. Rather, I should say I had to clean the data a little bit because not all the records are completely adequate. However, the standard of the data sources is quite high in general. It was the cohort studies and the smaller studies with 24 participants here and 8 participants there that requires a great deal of pluck and patience to look at for beta blocker and SGLT2 studies. I had to come up obviously with some inclusion criteria for the studies. I know everyone wants to include everything in these studies, but some of the study methodology doesn't lend itself very readily to meta-analysis. In particular, I had to exclude some studies because some of them included patients who were from Western countries, which biases the data. Another sort of clear rejection criteria for studies is if they didn't adequately report LVEF, mortality, hospitalization rates, um, medication dosing on a Corvidol equivalent scale, or if there was an unacceptably high margin of error in the study that made me believe there was some sort of methodological bias. So that's the inclusion criteria for our meta study, and there were many of them. You can read the paper. It's live in the Journal of Cardiology and Angiology if you want to see exactly how I did it. It's live and it's free. Here are some limitations. Number one, you have a number of heterogeneous study designs that make it very difficult to interpret sometimes what the ultimate outcome of the study is. Maybe it's a study of kidney failure, and I'm having to pull heart failure data out of a kidney failure study with a query. Limited pharmacogenetic data is also a problem, especially in low income countries where the reporting mechanisms are not as robust as, say, South Korea or Japan. And also, there's a certain sparsity of data for low income countries. This is a standard statistical problem where one has to interpolate sometimes what the overall averages and data dynamics are from very, very limited first steps. Luckily, this is a well trodden path, though one has to say with care what his conclusions are based on the sparsity of the data. But here's what I came up with in a nutshell for those who are interested. Japan by far had the highest rate of prescription for all beta blockers. China came in second place. All of these differences are highly statistically significant given the study sizes. Even a 2% difference would be highly statistically significant. South Korea coming up 65%, Singapore 71%, Indonesia 61%. So if one looks at the prescription trends, at first there doesn't seem to be a very clear trend line here, but as we'll see, the dosing practices are very different, and the main prescriptive trend is that a country's per capita gross domestic product is a very good indicator of its commitment to and availability to deliver heart failure care. Turns out Singapore and Japan and China all have quite good outcomes, and Indonesia is investigating a great deal more use of adjunctive therapy, though cost remains a very high barrier. If we look at the dosing practices, the difference between Western and the aggregated Asian dosing practices are very, very stark. I'll speculate on why that is. I don't have proof of it. If you'll notice, throughout the data I queried, and this has been reported in the Asian study, it's also been reported in multiple cohort studies. The median Asian dose of beta blocker is far, far lower than merely weight proportional reduction, far lower, statistically significant at the zero point zero 0.01 level lower. So there's something going on here because if you look at the clinical outcomes between Asia and the US and the UK, where we have records of very, very high doses of Corvidol equivalents dosing, we have very, very high confidence that the clinical outcomes are actually equal, despite the Asian dose being very much lower on average. And so the question of why that is still open, but certainly among Asian countries, the dosages vary. Japan having very low dosages, US of all countries where data is kept having the highest median dose of beta blocker, highest average dose, also a large standard deviation in the US data set, indicating the heterogeneity of the US prescriptive system and the presence of substantial clinical autonomy within that system. But all told, when you run the numbers by the law of averages, the Japanese, the Koreans, that these guys are getting the same outcomes for a fourth of the dose of beta blockers, and so the hazard ratios remain roughly the same over all the populations. Hazard ratio for sudden cardiovascular death or heart failure hospitalization in the American and European cohorts that I was able to query is roughly the same as for the Asian cohorts, despite a very substantially lower dose of medication for the Asian patients. And we don't know why that is. I tend to think there is a polymorphism of the cytochrome gene that metabolizes these medicines. As we'll go through, I'll attempt to hint at that, but I don't have a proof of it. And we might want to look and see, of course, I mean, safety is somewhat of a priority. There's a lower prevalence of adverse effects in Asia versus the US. If you query the safety profiles for all beta blockers, in the Asian studies, ASEAN, and the other studies that I mentioned at the beginning of this presentation, among other cohort studies, the discontinuation rate for beta blocker therapy in Asia is much, much lower than in the US. Maybe used to should be looking at the differences in statistical significance of the very much lower doses in the Asian countries than the US, causing substantially lower side effect profiles. Um, so at this point, I'll take a brief pause. I'll see if there are any questions. And all of this is just standard method of moment statistics. If you're interested in how I got it, you can read the full paper. Very, very easy, very tedious analysis that's, just essentially having to use massive data techniques to query messy data sets and come up with these things. Well-trodden machine learning stuff, okay? The only reason no one's done it before is that it's just very tedious. But the people in the paper, you can see now how to do it, and other people can come along and probably do a better job because I don't have supercomputers. So let's go ahead and change the strategy here. Let's look and see how and whether it's safe in the Asian cohorts because the dose of beta blocker there is so much lower. Could we get even better improved outcomes if we were to combine beta blockers with sodium glucose cotransporter 2 inhibitors like the D drugs, as I call them, unpronounceable SGLT drugs? You are doctors, you know better than me the physiology of these. They allow better renal excretion of glucose than one would have without them, and consequently, statistically significantly lower HbA1c and fasting glucose levels. They also have a renal protective function that's not well understood at present, and hopefully future research will elucidate. However, in Asian cohorts, it is definitely the case that combination therapy with sodium glucose drugs uh, even further improves the efficacy of the lower dose of beta blockers that you're seeing in the studies there. And so this is a strategy which shows how you can combine uh, different medications with different mechanisms of action and get higher outcomes than merely raising the dose of one, right? So, I mean, just giving people more beta blocker doesn't necessarily improve glucose outcomes in heart failure patients, and just giving someone SGLT2 drugs doesn't improve necessarily heart function, but taken together, they formulate a relatively coherent strategy for dealing with metabolic syndrome in lower doses than each alone. And so here are the mechanistic insights that I came up with. Why is it that Asian populations require so much lower doses of beta blocker drugs that allow them to be combined with co-transporter drugs? And the answer that I found is that slower metabolism due to polymorphic changes in how the drug is metabolized in the liver yields a higher sensitivity at lower doses. However, I don't have adequate proof of that. This is a best guess based on existing research outcomes. You can read the paper, query the data set yourself, or likely other people will come along and do that. I don't have a smoking gun that says this is the reason, but it certainly seems to be a likely contributing factor for why lower doses of beta blockers are so much more effective. The dose they give in Japan would hardly do anything to an American patient on average, but it's quite effective there. So you're looking at a population level at some sort of metabolic uh, di- difference. So what about sodium glucose cotransporter inhibitor drugs? How do they show up in different contexts, and are they safe? Unfortunately, when I looked at the raw data, the numbers, as they say, as usual, the prescription of these more expensive drugs correlates heavily with healthcare spending and access. So, if you want a good explanatory factor for the prevalence, for instance, in China of these new drugs, that the centralization of the healthcare system makes adequate prescription very much easier. Same in Japan. You have a national healthcare system. It has a very, very high and uniform level of care for heart failure patients. And so the minute researchers got out data that SG drugs were adequate, these were on the national registries there. Unfortunately, for those who don't have as much money, the strongest correlation is median healthcare spending, and the clinical implications for me across Asian countries, if you're looking at questions of cost and availability versus the clinical sort of picture generally of hospitalization and adverse events. I am going to suggest, based on my study tentatively, that lower starting doses of beta blockers should be should be used up to the point where patients are reporting side effects, or otherwise you have tiredness, you have nausea, you have bradycardia, you have hypotension, these sorts of things. And after that point, it's my suggestion, based on the data I've seen, that governments that have not introduced SGLT2 inhibitors as adjuncts to beta blockers will probably find it more advantageous longitudinally to do this early in the treatment protocol rather than upping the beta blocker dose. Drugs are very safe, the prices are dropping, there are generics available. Governments could invest in SGLT2 treatment and have a very, very good return on investment rather than just increasing beta blocker doses, which causes a whole host of side effects, as I've mentioned. What about adverse effects? Because we're dealing with lower doses of medication in Asian populations in general, the adverse effects of beta blocker prescriptions, bradycardia, hypotension, syncope, breathlessness, dyspnea, etc., is very much lower in the Asian cohorts, which also means that it would be more advantageous to increase SGLT2 doses in these populations rather than run the risk of the adverse effects that we find with the very much elevated doses in the Western world, which are sometimes cause intolerable side effects and have to be down titrated very carefully to stop rebound tachycardia or hypertension or even worse outcomes, right? In Asia as well as in the United States, as I've argued, in several pieces, what we need to come up with is a personalized medicine profile using the tools of AI and big data that we have at our disposal now. For the first time in history, we have an extremely good handle on massive amounts of data. It's high time that governments and health services invest in personalized medicine algorithms. The return on investment will indubitably be higher in this regard in the future, having everyone getting their particular needs met than having these one size fits all beta blocker dosing where the doses are too high or too low and there are 100 follow-up visits where people are having to titrate the doses or they're scared and they land in the emergency room and run a bunch of tests and there's nothing there because the dose was wrong. So governments should see personalized medicine as something that comes along with the big data revolution. We currently have the ability to personalize medication like never before. And I encourage those in health and human services who are watching this and those esteemed colleagues in the Chinese and in the Korean and Japanese medical systems to consider this as well. Use the data tools that we have to develop highly robust individualized treatments. It'll save you money in the long run, which leads us to future directions. Note that I didn't prove that genetic polymorphisms were associated with the difference in beta blocker tolerability. That's a question of pure science. We need more trials to come up with a causal analysis, and we need more controlled trials. The data is too messy, so given that most of you are physicians, I'm presenting my findings as heuristic rather than some sort of scientific certainty. I don't have a proof that genetic differences are responsible for the dosimetry differences. That proof would involve very, very careful, multi directional type analysis that could only be done in multi center aggregated trials and a double blind peer reviewed trials. That's the only way. We're going to have to see, I think, due to the prevalence of individualized medicine and the big data advances hitherto discussed, how pharmacogenetic profiling based upon individualized factors could possibly be a substantial money saving mechanism for governments, health services, insurers, and patients, dare I say, because of the lower prevalence of follow up for unnecessary emergency care, GP bookings, requests for referrals to specialists that are not medically necessary, up titration, down titration, dosimetric differences that could possibly be dealt with in an individualized way or by changing and adding an SGLT2 inhibitor to an otherwise adequate beta blocker dose without being too much relying on healthcare funding that's unnecessary. And I'll leave you with these key takeaways. We need precision medicine now, and we first time in history have the tools to do it. Combination therapy of beta blockers with SG drugs is very promising. The extent to which it's promising can be explored in further submissions and improved data query. The safety profile of combination therapy is fine in Asian and American patient cohorts, and the reduced doses that are effective in Asian cohorts offer an opportunity to combine lower beta blocker doses with SG drug doses and provide renal and cardioprotective effects beyond what would typically be effective, one drug alone. So there's a synergistic effect there. I thank you for your attention. I hope you have a lovely day. This is Dr. Jonathan Kenigson, the mathematical kind, signing off.